You can't ignore the fact of prostate cancer, but you don't want it to consume your whole life. That's where this group comes in. It's not a club, it's just people seeking answers from people who've had experience. Just zoom in when you want to know how others have got on with something. Put cancer in its place. Go on to live the fullest life on your own terms.
But at the last meeting, towards the end, Robert was talking about his PSA, and I just like, and he was going to go to the doctor, and Alan, I don't know whether Alan was actually on the meeting when he was talking about it, but anyway, we got an email from Bob about further details. So if you'd just like to give us, could you give us an update on where you're at on that one, please, Bob?
Yeah, I haven't found anything definitive about it, but I mentioned it to the GP, and he said the medication, I'm reading this from my email, is it's usually prescribed for, this is cytidocin I'm talking about, it's usually prescribed for BPH, benign prostate hyperplasia, which is just when the prostate expands with age. And he said, and this was backed up by a prostate cancer nurse I was talking to, that the cytidocin could actually bring down the PSA if the prostate at the time was inflamed or irritated or there's some problem there. The cytidocin would have had an effect on what was causing the irritation or whatever it was, and at the same time that would bring down the PSA. But the nurse said that she didn't think that would normally bring it down by that much, and it came down from 15 to 4, I think it was. But, oh, do you want to answer those?
No, that's right. It's Yanni logging
on. Hi, guys.
Hi, it went down to 4, but all of that happened before the biopsy. And I got a copy of the biopsy report, and alarming as it is, it doesn't mention anything about those horrible things that Alan was mentioning. It just goes through the different core readings. They did the summary in the dim light. They did 13 specimens. Can you excuse me a second? I'll just turn the light on.
Welcome, Yanni, anyway. Good to see you.
Yeah, they did 13 specimens. Prostatic adenocarcinoma in 10 of them out of 11 cores. The highest was 5.5, which was obviously 10. There was perineural invasion. In 2 of them, and prostatic adenocarcinoma in 10 of them. 3 of them were benign. I mean, that's all a little bit beyond me, but when you look at all the others, there were 2 at a Gleason 7, 1 at a Gleason 8, 6 at a Gleason 9, and 1 at a Gleason 10. And 3 benign, that added up to the 13. So, as I say, all of that drop in PSA was before this biopsy. And since then, it's continued to drop. The doctor I see is not alarmed by any of this. And he just says, we'll keep testing and we'll keep watching. And that's about where we're up to now. I don't see him again until next 2 weeks. I'll get tested last week. The last reading went up 0.03, which nobody seemed to, they said that's not significant enough to worry about. It could just be a hiccup in the measuring system. So that's about where I am at the moment, if anybody can throw any light. But as I say, it's come down now, and it's now 0.28.
Right. Anyone got a comment to make? Yes, Jim?
Bob, after the meeting, we were thinking of a couple of ways that it could have happened. One is that a medication that you are taking, the one you named, may be reducing the PSA. But a second one, a second one,
I thought I was muted, but I am now.
Okay, thanks. A second one explanation was that you, in fact, at your first measurement, had quite a large infection, and that was never treated. But your body naturally started curing the infection and slowly reducing your PSA all the time. So that was another one that we thought that we had.
It's all a bit hypothetical now, because this was all 18 months ago. And as I say, it was before the biopsy.
Yes.
So what are your current most recent PSA figure?
I haven't got the dates on here, but it's
roughly
about the latest was 0.28. About a month before that, it was 0.25.
Okay. So a comment I'd add to what I've said to you privately is that Jim's theory is certainly a candidate. It is possible, although hard to prove retrospectively, that PSA is retreating from a prior infection. I think the second element is the use of that BPH drug, which it would shrink the PSA. Would shrink the prostate, and consequently, because of the reduced surface area of the prostate, would reduce the amount of PSA it's producing into your bloodstream. But I tend to agree with the earlier comment that from the nurse that it's a very large drop in PSA to be explained by that. I think you expect possibly up to a 50% drop or something like that, but not the drop to the extent to which you had it. So my remaining concern, and it's by no means intended to be alarmist, but you do need to keep it in mind. Bottom line is, from your biopsy, you have high risk prostate cancer. That's just a reality. Irrespective of what the PSA is saying, the Gleason scores of 9 and 10, even 8, are, in my personal view, is the definitive data in your case. And I think it is a possibility, and it's only a guess on my part, and I'm not really qualified to make guesses, but I'll make it anyway, that if you've got mutation happening to your prostate cancer, which could have been established for quite some time, if it's changing to a form that doesn't produce PSA, and that often, not often, but fairly often happens after you've been on treatment for an extended period. That's called treatment emergent or treatment induced change. You can get different kind of cells forming that look more like nerve cells than prostate cells, and that's called neuroendocrine or small cell prostate cancer. And the only way of knowing whether that's the case is another biopsy. And I would think it's not the GP you should be seeking advice from to keep an eye on all this. It's a urologist, because I would think a second current biopsy in the context of the
urologist.
Urologist. The sort that attacks your prostate cancer and your bladder and what have you. So these are the guys that are, qualified to do the biopsy again and to have it assessed by a pathologist who knows what they're doing. It's simply pursuing one of the possibilities. It's by no means a lay down misere that that's happened, but it is a candidate given that you've got such high risk cancer with those Gleason scores. So I don't think that's a GP won't be across all of that. I don't believe. Don't quote me to any doctor, by the way.
That was just his suggestion. He said he obviously didn't know that it was a maybe. When you say another biopsy, obviously what to the prostate? Prostate.
Correct.
Yes.
I mean, it might sound like a pain in the prostate, but it's the only way of knowing whether that is a situation that needs investigating further. Whether a urologist would see it the same way, I have no idea. I'm just simply putting it out there as a possibility. It's hard to explain that degree of PSA drop from what I'm aware of. I'm not saying I'm aware of everything, certainly not, but that is one of the candidate theories.
Thanks for that, Alan.
Thanks, Alan. I'll follow that through.
If that were the case, Alan, the biopsy would already contain those cells, and the slides from the biopsy are preserved for years. So a second opinion from a pathologist, specially asking for that, would save a pain in the prostate.
Yeah, that's a fair comment, Jim. I think it certainly wouldn't hurt. You could do it serially, recheck, or have a different pathologist preferably, recheck the original block and see if they can spot any neuroendocrine cells. However, if they weren't there at the time and they've appeared since, it may still be necessary to have another biopsy. It's not the end of the world, a biopsy. It's just a bit of an inconvenience, but it's a good way of getting started early if you need to change the treatment, and that would be the outcome if you were to find that sort of neuroendocrine cancer. If they don't find it, you can cross it off your list and drop your anxiety levels, although it would still be an unexplained result. There may be other explanations that a urologist or a medical oncologist might have that I'm not aware of, but that's simply one of them. It's easily tested.
Yes, Yanni?
I'm sorry I came into this late, but wouldn't a combination of an FDG and a PSMA scan pick up whatever potential tumours there are?
Yeah, it's not a matter of finding. They've already found them, Yanni, but a question of what grade they are. And neither of those scans will tell you that. I'll tell you if you've got, PSMA on the surface of your prostate cancer, but as to what sort it is, even whether the PSMA expression differs between normal adenocarcinoma, which is the standard prostate cancer, or the neuroendocrine small cell version, I just don't know whether that differs from one to the other, but neither case will it tell you what the grade is.
Just
Yes,
a message to Graham.
Yeah.
Could you give this hand signal if you want to be heard?
All right. What was one?
Because that
I just wanted to ask Bob, do Did you mention neuroendocrine cells found in the biopsy already?
Yes.
No, I don't think so, Bob. Don't think
Sorry?
I don't think there's any mention of neuroendocrine disease in your biopsy report.
No, there's not.
No. Just
So every single one of them is adenocarcinoma.
Yeah.
Except 3 of them benign.
that was 2 years ago, is that right?
It was 18 months ago, yes.
Okay.
Well, yes, 18 months, I suppose. So when they mutate, do they mutate in the prostate or where they've spread to?
Could be either. But so I would think, given the fact you've still got your prostate and it's very easy to biopsy it, that would be the go. Whichever it was, it wouldn't change the treatment, or the decisions. So the biopsies, the prostate's a convenient target. It's pretty hard to biopsy tumours.
Any other comments for Bob?
Jim
Yes,
here
Jim.
with a general comment on PSA. PSA readings are very accurate, but not so reliable. That's engineering talk for. They've got a lot of decimal places, but when you do one after the other, even on the same blood sample, you won't get the same results. In other words, they'll vary a bit from measurements. So you never worry about small changes up or down. You're looking at things like doubling time, whether it's a significant change. So you don't worry about, don't sweat the small stuff. Okay, thanks, Nev.
Thanks, Jim. My concern about Bob's situation is his Gleason score. So I'd be putting more emphasis on the Gleason scores than the PSA.
Absolutely.
If it was me. But what would I know?
Enough to say that. So
anyone else got a comment?
No. So what do you think, Bob? You think another urologist or a second opinion urologist would be good?
Yes, I'll certainly do that. I'll ring up the urologist, perhaps make an appointment. I'll be going to Lismore to see the oncologist in 2 weeks. Maybe I could make an appointment about the same time and have a yarn with him.
Absolutely, yeah, raise it by all means. Oncologists will be across it, because it may well be that if that is the situation on rebiopsy, the medical oncologist that would be treating you, not a urologist.
Any further comments or questions? Rightio. Peter, did you get it commissioned?
Now, sorry, Jim, NBN cut out when you were talking about star 6 and star 9. So I wrote down star 6 and star 9, but I wasn't too sure which one was which.
Nothing to do with you. That's for people who are on an ordinary phone.
Oh, okay.
That's for Tony.
Oh, right. Oh, fair enough. Yes, I had my artificial urinary sphincter commissioned on October the 5th. And fortunately, my wife came with me so she could hear my almost scream in agony when he activated it. He warned me. He said, this is going to hurt. And he wasn't blooming wrong. I'm sure you've got one, haven't you, Yanni?
No, I've got one.
You've got one, Graham.
Yeah.
Well, yeah, a whole new level of pain in the nether regions.
Didn't get it myself, but anyway, lucky.
Yeah, well, it was bad. And then he had to tutor me on how to use it. And I wasn't allowed to leave the surgery until I got a 10 out of 10. Thankfully, I did. There was a few questions that I raised. things like lifting weights. No, I'm not allowed to lift weights anymore. Ride a bike. And my wife said, you haven't ridden a bike in 10 years. And I said, well, there's one sitting under the house and I might just happen to get on there one day. And he said, under no circumstances ride a bike. As in a push bike. I don't know what a motorbike would be like. And he told the story of a chap who was from the country, and he had one inserted or implanted, and he went home and he helped his daughter go muster some cattle, and he hopped on the horse and he blew the whole thing apart. So that's one of the things you're not allowed to do. I asked about flying because I wasn't too sure whether there was any deals with atmospheric pressure. No, that's fine. But I've got to carry a card with me to go through security because there's wire in the tubing. So that were the main things on that day. There's been a few minor setbacks. At the 10-day mark, post him activating it, my wife came home from work. I sat on the steps that lead up into the bedroom. We had a chat for how was her day, how was my day. We were only there for 3 or 4 minutes. I got up to get dinner ready and things just didn't feel right. And I was back to having to use a full pad 8 a day. So I went back to see the urologist thinking all the worst things. He checked me out and said, no, there's no issue. But because my bladder, he said, is rock hard from the radiation, I'm booked again for another injection of Botox into the bladder wall next Friday. I bit the bullet and went back to just trying to wear an adhesive pad to my jocks. And I must say that I've been successful for the last few days. So no more blooming pull-ups for Pete, hopefully. And then once the Botox kicks in, my wife and I are hoping to be able to get away for a little holiday. Her mum's down in Victoria. She's 93, still lives on the old family farm. So we thought we'd drive down and just take it easy and stop whenever I need to have a pee. So fingers crossed, everything's going to turn out fine.
Yes, Jim.
Just a thought, Peter, because of what happened, you might, for the next month or so, not sit down low and get up from sitting down low. Or if you do, haul yourself up on the railings of the steps or whatever.
Yeah.
The extra strain on standing up there was what happened.
Yeah, I'm not going to be sitting on any hard items, even a chair. I've got my whoopee cushion type thing on my chair here at the moment. So, and it's a padded chair as well.
Yeah, Graham. Sorry, Graham. Yeah.
Yeah, just a couple of comments. I mean, you've had a worse experience than I did, Peter, for sure. But yeah, the airport screening thing's a bit of a laugh. I said, what are you talking about? But they bailed me into a corner and tested me for explosives and all that sort of stuff.
Yeah.
I occasionally, and not so much these days, but occasionally got a bit of blood in my urine. Not ever sure what that was for. I never asked the doctor about it because it's kind of disappeared. Well, early on, I did have some problems with that. Well, now that I think about it, a bit of blockage, phone calls in the middle of the night, that sort of thing. But it was by walking around the house, I was able to clear that. Comes out of a big clot. But that's about it for that particular device for me. Now, since been, what, 3 years now I've had it in there, and it's since the first 6 months, I reckon, hasn't really been any trouble at all.
Thanks, sir. Thanks, sir.
People know I've got it. I carry a card which says how to attack it if I need to be catheterized, that kind of stuff. But apart from that, it's no big deal at all for me. So
thanks,
hoping. Good luck.
Thanks for sharing that experience, Graham. Appreciate that. Peter, did you consider a sling at all?
That was an option, but he said in my case, because of the level of radiation that I'd had, it'd be of no support for me. For what I'm not playing on words there, but the sling would not work, and it was going to be about $10,000 anyway. Whereas the actual prosthesis that he's implanted is something like $30,000. And I know when I was having the operation, there was a representative from Boston Medical actually in the theatre. Now, I wasn't too sure whether that was to hand over the golden goods or whether he was there to make sure that the urologist did it correctly and there was no claim back. I haven't worked that bit out, but yeah, he indicated to me that the artificial urinary sphincter was the golden method, and that's his preference.
Yeah. Libnan, thank you for coming. Welcome.
Hello, everyone.
Yeah. Jim, did you want to say something to Peter?
Sorry?
To Peter?
To Peter.
I thought you had your hand up before. That was all to ask a question to.
Talk to Libnan. It spoils our recording if there's any sounds in the background. So we ask everyone to stay muted except when they wish to speak. While you're muted, and if you wish to speak, very clearly raise a stop sign hand like that so we can see, and then give you a turn. Okay? Thanks very much.
Thank you. Yes.
Good.
Thank you.
Libnan, this is your first visit to this group. Were you happy to give us a bit of an update on where you're at in your prostate cancer life?
Yes, sure. Good morning, everyone. I've been diagnosed with prostate cancer 3 years ago. And the prostate cancer was also outside the prostate with some lymph. I started the hormone Urinary 45, which lasts for 6 months. I had taken 3 of them, which is 1.5 years. At the same time, I've done the TURB, and I've done brachytherapy, and I've done the radiotherapy. Now looks to me that it returned back. After I've done the PET scan and I've done the MRI, this is after the radiotherapy, then it looks that it returned back, and then I need a solution for that. So my specialists, we agree that I need to do an operation to take out the prostate. This operation, my specialist told me that this will be having a lot of permanent side effect. And I decided not to do it, because what I'm going to have, it will be more difficult than if I don't do it. I have only 2 choices. One of them, and he said that if you do the nano knife, which is not recognized by the Medicare and by the government so far, it costs about 26,000. And the nano knife, they use the electric current. It's similar to the brachytherapy. And even this, the nano knife is not guaranteed that will solve the problem. Okay. And the other choice is to continue with the hormone. So I would like to take your opinion and to have some idea what I want to do, that especially the nano knife is very expensive, but I'm thinking that if I can get any support plus what I've got some money to do it, if I see that is gonna help. Also, I'm expecting today or tomorrow a telephone call from St. George Hospital, because I would like to have a PET scan again. So my new appointment with my specialist on the 6th of November. So I take my PET scan and I can see if it's still inside the prostate or it's outside.
Can I just break in there for a second, Libnan, please?
Yes.
One of our members has got to go shortly, and I think he'd like to say something. I'm sorry to break in on you, but Alan?
Thanks, Nev, and thanks to Libnan. That's a pretty comprehensive story. One gap in it is your biopsy result. When you had first your diagnosis, you would have had a biopsy before they did any other treatment. Can you recall your Gleason score or grade group on that report?
Sorry, could you repeat?
Yep. The biopsy that you would have had earlier would have included a score called the Gleason score or grade group. Can you recall or can you check what those numbers actually were? The point of that is that it defines how aggressive the cancer is or may become, and it also, to a fair degree, dictates the appropriate treatment that you should be getting. So can you comment on that before I
I think it's a grade 4, and it's very aggressive.
Okay. So grade 4 basically means Gleason 8, which indicates that it is fairly aggressive. There are more aggressive versions, grade 5, which would indicate that it's metastatic. And I think you did say that you had some, from the PSMA PET scan, you had lymph nodes which were visible. So if that's the case, I mean, we're saying grade 4 is the top grade. It indicates that it's metastatic. The Gleason score, which I commented on earlier, is a different figure, and that the grade 4 simply is an overview of whether it's metastatic or not. The Gleason score, which will be a figure of 8, 9, or 10, or perhaps called a grade group, which is 3, 4, or 5. That's an important number for you to know. If you're able to tell us, that will help us to comment further.
I don't have the result with me now. I should have it, yes.
But
as far as I know, it's not metastatic so far.
Well, if you did mention you had lymph nodes which were showing up on the PSMA PET scan. If that's the case, then it is actually metastatic. That would define it as grade 4 in terms of its level. But the other comment in relation to your question about further treatment, you mentioned you'd had brachytherapy. That's radiation treatment based on, depending which kind you had, either based on radioactive seeds or needles through which they pumped radioactivity. Either way, that tends to make physical surgery a bit more of a problem. You'd need to have a really close conversation with any urologist who is proposing to remove the prostate, just to make sure that they're aware of the radiation treatment and they're satisfied that they can do it safely. So that's a second point. The third point I'd make is that, particularly if you do have metastatic lymph node involvement, but even with whatever, if it's grade group 4, that those two things go together. It's good. Oh, giraffe. Excuse me a sec. Okay, sorry about that. I've got the phone on, forget the internet. I was about to say that you may want to talk to your medical oncologist if you have one. If you haven't, it's probably a good time to enrol one, about additional systemic treatment, medical treatment. You say you're using Libnan. That's the most basic form of treatment. And these days, if you've got metastatic disease, that wouldn't be enough. You normally would have either a few rounds of chemotherapy, which is docetaxel, to accompany the ADT, the Libnan, or you would start to look at adding either enzalutamide or Zytiga, or potentially even both if it was a really high-grade cancer. So I just think you've got a bit more conversation to have with your specialists, but certainly before you undergo any surgery.
Yeah, thank you so much. Thank you so much for your opinion, and thank you so much.
With that, I'm afraid I have to bail out. Neville, if you want to share my phone number, if Libnan would like to take that further, by all means, I'm happy to over the phone. But I do
sure.
Thanks very much, Alan. I appreciate your time. Graham, I'll get to you in a minute. Yanni, I'll get to you in a second. Graham might have been just waving goodbye to Alan.
Yeah, exactly right.
Yeah, good. Well done. Libnan, this meeting is being recorded. You have no problem. You don't have a problem with that at all, or?
Yes, sure. I have no problem at all.
Because JimJimJimJim up in the top left-hand corner, he will turn it into a YouTube video, and you will get a copy, and you'll be able to view the meeting, so you will as well. So you'll be able to go back through the meeting and see any comments that have been made. So you will down the track. Yeah. Okay. Now, Yanni.
In terms of treatment options, my understanding is that the nuclear medicine that lutetium-177 is being recommended for earlier use than post-chemo nowadays. So maybe that's something that you could explore as well, because that can be very successful in identifying where any tumours are, and then wiping them out before you proceed on anything, I suppose, more dramatic. Jim?
A technical thing first. To save people having their hand up like that for a long time, if the chairman sees them, and the chairman can point to wherever they are on his screen, and then they'll be able to put it down. Okay. My question to Libnan is the lymph nodes. Did they show up at first or only at the end?
At first.
Right.
At first. Then up.
So Alan's comment about metastatic is absolutely correct. If it's outside the prostate, it's called metastatic by definition, but if it's only in the lymph nodes, particularly the lymph nodes down near the prostate, they don't count it as that. So in their score system, they put an N1 for there are some lymph nodes, but they put an M0 for saying there's no metastases. So what you have is you haven't reported any distant metastases, any metastases that are a long way away from your prostate. If they are, say up here, that's definitely metastatic. But down near the prostate, they don't count as metastatic.
Correct.
And I agree with Alan's comment that you'd be wise to look at other treatments beforehand. How long ago did you have your last hormone therapy injection?
I took last hormone needle 1 year and a half.
Okay, so the very first thing that would be considered, I think, is if it comes back, putting you on hormone therapy. Mine came back 8 years ago, and I went on hormone therapy again, and that was 8 years ago, and it's undetectable at the moment. So all the way through. So that would likely be to be a first treatment.
Peter, sorry, Jim. Peter, did you have a comment?
Well, I'll let Jim finish first, but yeah.
He's finished.
Oh, is he? Oh.
Yeah.
Yeah, I agree with Alan in that you need to establish, is it metastatic? Because in my case, it was prostate, lymph node, spine, and ribs. So at the outset, the oncologist said there's no point in removing the prostate because that could actually make things worse. So that's just my own personal circumstances. So Jim?
Firstly, Nev didn't do any pointing.
Yeah, but I can't get it to work.
Oh, okay. Yeah, you're forgiven.
Thank you.
The other thing that happens on recurrence is more radiation. The fact that you have had radiation doesn't stop more radiation from the same spot. In fact, although doctors often say, after you've had radiation, there's only surgery. That's a furphy. The most common treatment is radiation. Again, the only reason I went on hormone therapy is I wasn't a suitable candidate for radiation because I've lost most of my innards, and the rest are all twisted out of shape and so on. Yes, so medical oncologist is the person who would probably be guiding you at this stage of your treatment, and you keep your urologist on the team because there's some things that only they can do with surgery. Thanks, Nev.
Thank you.
Libnan, I'd just like to ask how long you've had hormone therapy for, how often you had the injection, how did you have it every 28 days, every 84 days, 168 days, or what was the time span in between injections, and how long they lasted for, and whether it was a year or 2 years, or why did you stop?
Okay. I took the hormone for 1.5 years.
Yep.
Each injection lasts 6 months. I stopped them because they said the treatment takes 1.5 years. And at that time, everything was fine because my PSA was undetectable. And I stopped taking anything else. Then my PSA started to grow up very fast. And at the moment it's 2.1. And it was 2 months ago, 0.7. At the moment, I'm not taking any medication, but I'm going to do the PET scan, then see my specialist on the 6th of November. And after that, we will decide. My plan is to look at the nano knife operation, because so far in the PET scan, it didn't show that there is outside the prostate any cancer cells.
How did you, just before this, Jim, just how did you tolerate the hormone therapy? Did you tolerate it okay, or did you have difficulty with it?
Yes, was fine. The side effect wasn't difficult for me. Only some hot flashes and
Yep. No worries. Jim.
Nano knife is just another form of surgery. It's not as you said. It's still not mainstream, not recognized, and it would be unusual to recommend it. In my experience, and remember, I'm not a doctor or anything. I don't know why if it is there in if the extra is identified there in the prostate, why radiation wouldn't be the first choice, and hormone therapy another choice, maybe at the same time, but yeah, okay, thanks.
I just remind Libnan, none of us are doctors or medical people, so we can't give medical advice. We're just sharing our experience. So yeah, yes, Graham.
Just going to say, my treatments go back a number of years, but obviously, my hormone therapy back sort of 10 years ago was not Lucrin. It's Zoladex, and it still is Zoladex, by the way. That continues. But I used to, my PSA used to drop down to undetectable after a couple of shots. They were 3 monthly injections, those things. And then it'd be okay, keep measuring, it's all okay for about another 18 months. And then it'd start to rise again. I had hormones again. Same thing happened 3 times. So between surgery in 2006 and then 2014, so now 9 years ago, that was happening. Then I had in the 2014, the PSA was going up, down around those 1-2 levels, despite the fact that I had recent hormone implants. So I'd had a PET scan back in the day, and as Jim's alluding to, the result of that, they found, I'd had surgery, by the way, but they found recurring cancer in the prostate bed, and they found a lymph node with cancer. Excuse my voice, but my mouth is very dry. So radiotherapy was what I had on both those spots. Normal, excuse me, normal radiotherapy on the prostate bed and SBRT, which stands for whatever it is, stereotactic, on the lymph node, which cleaned both those up. Subsequently, recurrence elsewhere has occurred, as determined by more PSMA PET scans, and I've had a lot more treatment. But what happened to me sounds a little bit like what's going on with you, Libnan, that you need to be talking to a team, radio and medical type oncologists, and the urologist, and get their best advice on how to go.
Thank you. I feel I'm neglected. I feel that I should take something now. Anyway, I'm waiting now after 6th of November, see what will happen. And I'm not sure about the nano knife. As you said, it's new, but I will take the opinion of my specialist and see how it's go.
What happened to me, Libnan, was when I first went on to hormone therapy. This was back in 2011. They wanted to take me off it when my PSA came down. So I just left the oncologist and went and found another one. So I did, because I didn't want to be going on and off it, because I just thought I'd be better if I just stayed on it all the time. And that's what I've done. And my PSA is still undetectable to this day. So it is, because numerous times different doctors have wanted to take me off hormone therapy, but I haven't taken that advice. So yeah, Yanni?
Yeah. Yes.
I was going to say the same sort of thing, Nev, then supplement perhaps the hormone treatment with some stereotactic radiation to your nodes, and that should cut it back for a while at least, and wait and see how you progress from there.
Can I do the radiotherapy again for the lymph? Because I've done it before.
Yeah.
Oh, yeah. This is. Yeah.
But stereotactic, as you probably know, pinpoints exactly where the tumor is, and it comes in from different directions into a focal point, so it doesn't damage the flesh and the cellular material around it. So it's not a broad radiation treatment. So that can be directed specifically at your lymph nodes.
So similar to the brachytherapy.
Yeah, and then if you continue with your hormone treatment, then that will also reduce the size of the tumor within the prostate.
Yes, thank you. Yes.
Jim, did you want to say something? Yeah.
Yes. On the hormone therapy, going on and off hormone therapy is called intermittent hormone therapy. They did a study looking at the difference between those who went intermittent and those who went continuous, of people who had very high risk cancers. And statistically, they didn't find a difference between the two. But looking at the people who did the intermittent, who had high Gleason scores, they only had 14 of them, and that wasn't enough to draw any conclusions statistically. Nevertheless, they lasted on continuous a considerable length of time before compared to those people who went intermittent. So when it came to my case, it's a good idea after you've had your hormone therapy to stop it, because it may have worked for the rest of your life. But after it came back, I decided I was going to take hormone therapy for the rest of my life. Not statistically good evidence, but the only evidence I knew of. And I'm still here 14 years later, or 8 years after the recurrence. So thanks, Nev. Thanks, Libnan.
Thanks, Jim. Libnan, do you have any sons that in your family? Any sons?
Yes.
Because you've got sons, they're more likely in the future to get prostate cancer, so they probably need to be checked for their PSAs from an early age, probably say at least, not older than 50 anyway. Some might even suggest younger than that on a 12-monthly basis.
My oldest son is 30 years old.
Right.
Yeah, that's right. Yes.
Yeah. So just keep that in mind.
That's right. You're right. Thank you.
Yeah.
Correct. Yes.
Any other? Yes, Jim.
Just an aside. Before I forget it, Rodney Danavig messaged me on Facebook a few minutes ago to apologise for he couldn't get here today. Okay, back to you.
Thanks, Jim. Graham?
Thanks, Nev. I just thought I'd better say why I'm wearing this costume and why my mouth gets dry. Last time there was a meeting, I think it was 5 weeks ago, I pulled out because I was in the MRI tube. Long story short, they picked up a possible crack in my C1 vertebra. As my daughter says, shit, Dad, that's right in pole position. And it is. And I had a really, really sore neck and pain shooting up the back left-hand side here behind my ear. And what happened was I talked to the palliative care people who I've got on 24/7 over here. And they sort of said, scary, scary. It might be spinal cord compression with that sort of comment. So I saw the medical oncologist and he felt around and he decided that he thought probably it was muscular, your old stiff neck type problem. But because cord compression had been mentioned, that's the magic word, self an MRI. So it did. And as I say, it turned out it's due to the cancer. So I've had the whack-a-mole, 10 fractions of 3 Gray. That finished 2.5 weeks ago. Pain's all gone, but the neck feels just a little bit unstable without this collar on, so that's why I wear it. The radiation oncologist and the medical oncologist both talked to a neurosurgeon or some sort of neuro guy anyway, and they said, well, if it was due to a motorbike accident, this guy had been a hard collar and, in traction and all that, but he's old and whatever, so we'll just give him a cervical collar, which is fine, it's working well. So that's all good, except I've now got I've got restricted saliva, a little bit of loss of taste, and so now I'm struggling to talk again with a dry mouth. Excuse me. Lick, lick.
You've had way too much experience, Graham.
Sorry?
You've had way too much experience.
Yeah. So that's that thing. Just so you know.
Yeah, no, I appreciate that.
Not a happy outcome, but we're managing.
Yeah, well, I'm pleased to hear you're managing. That's great news. So it is. Yeah, and all the very best. We're thinking of you.
Yeah, I got other issues, as I've explained before, but
yeah, I know.
Palliative radiotherapy, just as a general comment, for me is working a treat.
Good.
I've had it for the cauda equina syndrome, which is the paralysed arse, and that's all manageable. That's 18. Well, that was, I don't know, way back. I've had it for thoracic spine. I've had it now for cervical spine. I've had it twice in my hip, and I would have to say the hip's the one that's not working so well. That is sore, and that's got me on pretty strong pain medication these days.
Right.
I'm hobbling around a bit, but apart from that, I'm good.
I'm pleased about your very positive attitude.
All right.
No, you.
By the way, I should say before I quit, behind me over there on the shelf, you'll see a couple of lenses and a camera. I can't use them anymore because I can't bend my neck or anything. So any offers, it's a Fujifilm X-T4 and a couple of lenses. If anybody's interested, they'll be on eBay shortly.
Righto. Thanks.
Okay.
Thanks, Graham, and it's good to talk to you. Good to see you. You've missed a couple of months, so it's good to see you again today. So it is, yeah, and we wish you well. Tony Sheehan, have you got anything to say or comment on?
Am I unmuted?
No, you're fine. We can hear you.
Nothing in particular except about hormone therapy. I'm on Lucrin more or less constantly now, except through the warmer summer months, because I suffer particularly with hot sweats. I have a break off the Lucrin through the hotter weather, but I monitor my PSA constantly to make sure that the PSA is not rising. And I've found from experience that if you've been on a hormone therapy for a long period of time, then the effects of it are very lingering, and it takes a long time for your body to recover the ability to produce testosterone. So it's just something that works for me.
Thanks, Tony. Peter?
Tony, I know you can't see this and you're just on a phone, but I've been on deferralline injections every quarter, and I'm also on enzalutamide tablets each day. And I, along with you, suffer extremely with hot flushes. And my wife came home the other afternoon after work, and she produced this little package and put it on the table in front of me, and she said, "Here, this might help." And you pull it out, and it's a little fan. And I can go like this when I'm sitting at the dinner table, which is I'm the main cook and bottle washer because I'm retired, my wife's still working. So by the time I'm finished making meals, I even get hot flushes while I'm making the meal. I can sit here like this instead of using a magazine or something, and then it just folds back up like that, and you can just put it away and you can put it in your back pocket. She bought it.
Yeah, I was just going to say it's just what would be regarded as a fold-up fan, hand-operated thing.
Tony, if you could imagine those fold-up sunshades that you can use on the beach. No, they sort of twist and they fold up smaller. Well, it's a mini version of that. And it's the only manly one that she could find was one with some snakes slithering around on it. I don't know whether that was intentional or not, but anyway. You can edit that out, Jim.
I'll keep
an eye out for one.
You get the YouTube videos, Tony?
I do. So, I'll be able to have a look at what...
We'll bring you up to date then.
He's talking about.
Yeah, it's pretty simple.
It's certainly a lot cheaper.
While I've got everyone's attention, I've got a question for Yanni, if he's still online.
Yes, Yanni's here.
Yeah, mate. Yeah, Tom.
Did you receive an email from me?
No.
Because I wanted to contact you to exchange contact details, and I got what I thought was an email address off Nev to send you a message, but I never got a response. So
That's because I never got it.
That explains that.
So,
Have you got an email address you can give me, or what?
Yeah, sure, mate. It's very common for people to
Yes. So Jim reminds everybody that there is a button next to, it's usually next to the green button that says share screen, and it says chat. And when you press that, only people on this call can do it. And if you're very clever, you can pick on the guy's name and send it directly to the person. And that does indeed keep your email address private. But we will ask the editor to especially look at blurring your words or cutting you out. Yes.
Yes, Graham.
Can he see if he's on the phone? Can he see that? He can't see that the message box.
No, Tony.
No.
Technology failed.
He's blind.
Tony is just on an ordinary phone.
Yeah.
And he's just speaking into it.
Right. So
there's only two things he can do. He can press a couple of the phone keys to mute himself, or press a couple of the phone keys to put his hand up.
Yeah, good. It's all there.
Rightio.
I'm 20th century.
That's fine. Anyone else got a
Okay,
comment?
I'll give that that email another go, Yanni, and see how we go, eh?
No worries, mate.
Yanni had his hand up, Jim.
Well, just on the same point there, that there are some drugs whose names I don't recall now that deal with hot flashes. They're tablets you take to deal with hot flashes. I'll let Tony, I'll send Tony a copy of my information about that. Thanks, Nev and Yanni.
Libnan, I'll give you the call after Yanni. I think Yanni wanted to say something.
I subscribe to a whole bunch of sites on prostate cancer and what have you, and there's this new U-But drug that apparently has appeared, and it's in stage 1-2 trials, and it has a totally new method of operation. And I wondered if Jim has ever heard of it, because he's the smartest amongst us. It's called ARX517. Have you ever heard of that?
I have heard of it, but I know nothing more of it at the moment.
Yeah, it's got a chemical name longer than a yardarm. So, and it has apparently proved itself to be very successful during these trials. It's a series of 5 or 7 or something tablets that you take, and be keen to learn more about it, and if it's destined for Oz.
Thanks, Yanni. Libnan?
Yes, first I would like to thank everyone that really, even if it's a short time, but I got a lot of information. The first thing that my feeling that I don't live that long with the prostate. I thought there's gonna be a few years, but I'm so happy to hear that 14 years, 9 years. Okay, so my feeling that it won't take that time and where I live. So this is will be helpful for me, encourage me. And this Zoom, is it monthly, weekly, or how? This Zoom session.
Nev, you're muted.
You
Nev?
muted. Yeah.
What Nev
You're muted.
You are muted.
Sorry. Yeah, someone wanted to speak. I don't know who.
Libnan is asking how often these meetings are.
Oh, that's right. I told him and he couldn't hear. Yeah, right. Sorry. It's on the fourth Friday of each month. And but you will get a notice on the weekend before.
Okay. Thank you. Yes.
And Alan, that was on earlier, that left early, he's been on treatment for over 20 years. So he has. So we've got another member that's usually here that's been on treatment for over 20 years. And he was one that helped Jim up in the top left-hand corner start this group. So, yeah, he's not here today, which is very, very unusual. So, yeah, but he's been on treatment for over 20 years as well.
Okay,
so I've only been on treatment since, well, I've had my prostate out in April 2009, so I'm only a newcomer. So I've only been 14 and a half years.
Okay, so I've been for 3 years.
My PSA is still undetectable, as I said earlier. So, yeah.
Yeah. Yeah, because I'm not taking anything at the moment. I felt that I should be on treatment, should be taking something. Anyway, as I said, I'll wait till after I see my specialist. And it's also a good idea that see if another option to change my or go to oncologist, another new oncologist. Yeah, this is an option. Yes.
Yeah. Continuous hormone therapy.
Nev,
Jim.
Firstly, wherever I am on the screen is pretty random. I'm not on everybody's top left. So you better say that I'm the grey-haired guy with a beard floating in space, or some other identifier, or just say Jim will give you a wave or something like that. Secondly, Libnan, while you're writing things down, this will be on the video recording anyway that you'll be sent. If you go to JimJimJimJim.com, that's the word Jim 4 times, .com, and you go down to the on that page there's a contact box, and if you fill in that contact box and press submit, an email will go to both Nev and I, both of us, and we'll be able to answer any questions or put you in contact with someone else or whatever you need. Thanks, Libnan. Thanks, Nev.
Thanks, Jim.
Thank you so much. Yes.
Rightio. Anybody else got something to say or questions to ask? Yes,
well, my
Yanni?
latest update is that I keep on having my blood tests monthly, and I'm now still on. Now I'm on diferoline every 3 months, and still taking Enza and my enzalutamide, and my blood test PSA levels are still at below 0.010. So it's all working. It's all good. And Libnan, that's now been since 2011. So 12 years. And just an aside, prior to Zoom and a few years ago, there was a chap called Bruce here who used to be a medical practitioner. Is he still around, or?
Bruce, a few months ago.
Oh, did he?
Yeah. He was. Bruce was very, very old when he passed away, though.
88, I think.
Something like that, yeah.
Okay.
Well, he's old from where I sit from.
Yeah, we're all young.
Yeah.
Yeah.
Never mind.
Yeah, thank you so much.
Thanks, Libnan. All the best.
Thank you so much. Thank you, everyone.
Rightio. Anybody else got a quick word to say, or? Well, thank you very much, everyone, for turning up today. I appreciated your input. It was good to see you back, Graham. And I hope your neck improves. So, and all the best. Right,
Thanks.
and all the best for your sphincter, Peter. So
Yeah,
hope that
thank you.
goes well. And Bob, I hope you can find out what's really going on with your PSA and your cancer. So I do. Yeah. Tony, thank you. Thanks, Shani. Thanks, Jim. All the
Bye.
best, everyone.
Nev, thank you, Jim,
Bye.
and goodbye all.
Yep. Thank you.
Thanks, Nev, and goodbye to
You're
everyone.
welcome, Tony.
Yeah, thanks, Nev.